Welcome back to the deep dive. We're here to unpack those core concepts you really need for advanced clinical practice. Today, we're getting into the absolute bedrock of safe prescribing, pharmacokinetics, PK, and pharmacodynamics, PD. Our goal isn't just definitions. It's about giving you that working knowledge to, tailor drug dosing and really manage risk for your patients.
Yeah, it's easy to fall back on standard doses, but
Yeah.
well, it's often not enough. The second you give a drug, there are two things happening at once: what the body does to the drug, that's PK,
Hmm.
and then what the drug actually does to the body, that's PD. You really can't understand one without the other. If you do, you're kind of flying blind. Integrating both, that's the aim of rational pharmacotherapeutics.
Okay, so let's start with the target we're always aiming for, the therapeutic window. This isn't just theory, right? It's the real-world zone we need to stay inside.
Exactly. Think of it like a safe passage. Below a certain level, the minimum effective concentration of the drug just isn't doing its job. But go above another level, the toxic concentration, and you're risking serious side effects, unacceptable ones. The therapeutic window is that critical space in between. It can be pretty narrow sometimes. Everything we talk about with PK, the whole ADME process, it's all about keeping the drug concentration right in that sweet spot.
And that window is constantly shifting based on the patient's own ADME profile. So let's kick off with A, absorption, and this key idea of bioavailability, or F.
Bioavailability, yeah.
Right.
It's basically just the percentage of the drug you give that actually gets into the main bloodstream with the systemic circulation. When we give a drug IV straight into the vein, well, that's 100% bioavailable. That's our gold standard. But give it orally, and suddenly it's got obstacles, has to get across cell barriers, that phospholipid bilayer you mentioned.
Yeah. And solubility is king here, isn't it? Lipid-soluble, hydrophobic drugs, they tend to pass through more easily, whereas water-soluble, hydrophilic ones, they often have a harder time. And once absorbed, it often just moves down the concentration gradient passive diffusion. Fick's law governs that.
That's right. And the practical bit about Fick's law is time. Bigger molecules, they move slower across those membranes.
Yeah.
That's why particle size can matter. And some drugs, maybe highly lipophilic ones, they might even use active transport, which is limited, to get across faster.
Okay, but here's where risk really starts to creep in for oral meds. The first pass effect. Absorbed from the gut, straight to the liver.
Ah, yes. The liver is like this major processing plant right at the entrance. Some drugs have a really high hepatic extraction ratio. Take lidocaine, it's about 0.7. That means 70% gets metabolized, chewed up by the liver before it even gets a chance to circulate. That's exactly why you have to give lidocaine parenterally, like IV, an oral dose. Pretty much useless.
And so we often compensate for that for drugs with high extraction just by giving a much bigger oral dose, right? Like propranolol.
Precisely. You might need, say, 40 milligrams of propranolol taken orally to get the same effect as just 1 milligram given IV. It shows you just how much can be lost on that first pass through the liver. Clinically, if you know that extraction ratio is high, you might think about other routes, sublingual, under the tongue, or rectal, to bypass the liver altogether.
Okay, moving to D, distribution. Once it's absorbed, where does the drug actually go?
Blood flow is obviously key, like in shock. Poor flow means poor distribution. But beyond that, it's about protein binding, isn't it? This is super important, a real clinical pearl. Only the unbound, the free drug, is actually active pharmacologically. The portion that latches onto plasma proteins, usually albumin, it's just sitting there. It's inactive like a reservoir. Now think about your patient. Malnourished, liver failure, bad kidney function. Their albumin levels might be low. And if albumin is low, more drug stays free. That means a higher active concentration, potentially causing toxicity, bang, right away, even with a standard dose.
Wow, okay. That connects directly to this concept of apparent volume of distribution. You said it's theoretical, not a real volume.
Exactly, it's a calculated number. It basically tells us how much the drug seems to have spread out from the blood into the rest of the body tissues. It relates the dose you gave to the concentration you measure in the plasma. A low V-dollar, maybe less than 50 liters, that suggests the drug is mostly stuck in the blood, usually because it's water-soluble or heavily bound to proteins. The clinical point. These drugs are often easier to pull out with dialysis if needed, but a high V-dollar, say over 150 liters, that drug has gone wandering. It's likely lipophilic, spread deep into fatty tissues, maybe even cross the blood-brain barrier, and those drugs. Very, very difficult to remove by dialysis in an overdose situation.
Got it. Okay, let's tackle M&E, metabolism and elimination. Metabolism, mostly liver work, right? Making things water-soluble so the kidneys can kick them out.
Right. Metabolism, or biotransformation. This is ground zero for drug-drug interactions. The liner uses two main phases. Phase 1, things like oxidation, often involving the CYP system, and Phase 2, conjugation, adding something to make it water-soluble. But that Cytochrome P-450 system, the CYP enzymes, that's the big one for risk management, like CYP3A4, which metabolizes common drugs like atorvastatin.
And the risk really boils down to two main things happening with those enzymes, induction and inhibition.
Exactly that. Enzyme induction means the system speeds up. Metabolism goes faster, so the drug level in the blood drops. You might lose the therapeutic effect. Enzyme inhibition is the opposite. Metabolism slows down, the drug hangs around longer, levels build up, and you risk toxicity. You have to be constantly vigilant for these. And don't forget prodrugs. Sometimes we give an inactive drug on purpose, relying on the liver's metabolism to switch it on. Codeine becoming morphine is a classic example, or enalapril turning into enalapril.
And then elimination, mostly via the kidneys, filtering it out, actively secreting it. The time it takes to clear the drug really drives how we dose it. Which brings us to half-life. Brief half-life.
Yeah, simply the time it takes for the amount of drug in the body or the plasma concentration to drop by half, 50%. And the rule of thumb, the one you really need to remember, is it takes about 3 to 5 half-lives to do two things. Either clear almost all the drug out, about 97% gone, or, if you're giving repeated doses, to reach steady state. Steady state is that point of equilibrium where the amount of drug going in equals the amount going out.
And most drugs follow first-order kinetics, where how fast it's eliminated depends on how much is there. More drug, faster elimination. But the risky one is zero-order kinetics, where it's a fixed amount getting eliminated per hour, no matter the concentration. Like alcohol. That's where levels can shoot up fast if you overload the system.
Right. And that half-life has direct dosing implications. If a drug has a really long half-life, think digoxin, maybe 39 hours. You can't wait 5 half-lives, that's days, to get a therapeutic effect. That's precisely why we use a loading dose. A bigger initial dose to fill up the volume quickly and get the concentration up to the therapeutic window. That loading dose calculation, it relies on the V0. Then, the smaller, regular maintenance doses are calculated based on the half-life to keep it at a steady state. This isn't just theory. It's essential for safe, advanced practice.
Okay, let's switch gears then. We've talked PK, how the drug gets around. Now, pharmacodynamics, PD. If PK was about concentration, PD is about the effect, right? What happens when the drug meets its target, the receptor?
Exactly. PD is all about the drug-receptor interaction. The drug is like a key, the receptor is the lock. There are different receptor types, gated ion channels, G-protein coupled ones, and so on. But the core principles of how that interaction works are pretty universal.
So let's talk about affinity. That's how tightly the key fits the lock.
Pretty much. High affinity means a strong attraction. The drug really wants to bind to that receptor. Clinically, what that means is you usually need a lower concentration of a high-affinity drug to get a response.
And structure is crucial here too, isn't it? This idea of chirality or stereoselectivity.
Oh, absolutely critical. Chirality means many drugs exist as mirror images like your left and right hands. They're called enantiomers. The classic mind-blowing example is dextromethorphan and levorphanol. The D isomer, dextromethorphan. Common cough suppressant you buy over the counter, its mirror image, the L isomer, levorphanol. A potent narcotic analgesic, a strong painkiller. Same atoms, just arranged differently in 3D space. But the receptor only interacts properly with one shape to produce a specific effect.
Wow. Cough suppressant versus potent narcotic just based on shape. Okay, now function. Agonists versus antagonists.
Right. An agonist is a key that fits the lock and turns it. It binds and initiates a response. It has intrinsic activity. An antagonist is a key that fits the lock but doesn't turn it. It binds, often very tightly, high affinity, but it just sits there, blocking the lock. It has no intrinsic activity itself. It prevents the natural key, or another agonist drug, from binding and working.
And the classic clinical antagonist example has to be naloxone, Narcan.
The perfect example. Naloxone is a high-affinity antagonist for opioid receptors. It literally competes with opioids like heroin or morphine, bumps them off the receptor, and because naloxone has no intrinsic activity, it reverses the opioid effects, like respiratory depression.
Okay, and finally, how do we compare drugs? Potency and efficacy.
So potency is about the amount of drug needed for an effect. Hydromorphone is more potent than morphine because you need a smaller dose, fewer milligrams, to get the same level of pain relief. Efficacy, though, that's about the maximum effect a drug can produce, regardless of the dose. A full agonist can produce the maximal response. A partial agonist might bind well, might even be potent, but it can never achieve that same top-level effect as a full agonist. Its efficacy is lower. You really need to understand both when you're choosing between drugs for a patient.
All right, let's bring this all together into practice, customizing the dose based on the individual. We can't do that safely without a good handle on renal clearance.
Yeah, directly measuring clearance is just not practical day to day. So instead, we estimate it. We use the serum creatinine level to estimate the glomerular filtration rate, GFR, or creatinine clearance, CRCL. We've got formulas for this. Cockcroft-Gault is an older one. MDRD, CKD, EPI are more common now. They try to adjust for things like weight, age, sex, and sometimes race to give you a better personalized estimate of kidney function. And what's the key number that trigger point clinicians need to watch for with renal function?
The main threshold to remember is a CRCL, or estimated GFR, below 50 milliball per minute. Once it drops below 50, that suggests significant kidney impairment. You likely need to reduce the dose of renally cleared drugs or maybe give them less often, stretch out the interval to stop the drug building up to toxic levels. And the rule of thumb, you really must formally check renal function, calculate that estimate for any patient over 65 or R for anyone whose serum creatinine is above 1.5 milli-GDL. Don't just eyeball it.
Okay, super important. And beyond kidneys, things like age, genetics, even diet throw huge wrenches into the works for PK and PD. Age seems to affect everything.
It really does, especially at the extremes. Neonates. Their metabolizing enzymes might not be fully developed yet, so drugs can accumulate. Kids sometimes, counterintuitively, can actually metabolize faster than adults for certain drugs. And then older adults, you've often got, well, just general physiological changes, maybe less body water, more body fat affecting distribution, and almost always some decline in renal function affecting elimination. And then there's pharmacogenomics, your genes determining how you respond.
Exactly. Some people have genetic variations that mean they have enzymes that work super fast or barely at all. This can make drug responses incredibly unpredictable. Ethnicity can sometimes correlate with these genetic factors or other physiological differences. For instance, patients of African American descent often respond less well to ACE inhibitors alone for hypertension, possibly because they tend to have lower renin levels to begin with. The drug's target just isn't as active.
And diet. We absolutely cannot forget diet. It can turn things dangerous fast.
Oh, the classic dangerous one is MAO inhibitors, those older antidepressants or anti-Parkinson's drugs, and tyramine-rich foods. We're talking aged cheeses, cured meats, some wines, fermented things.
Yeah.
MAOIs block the breakdown of neurotransmitters like norepinephrine. Tyramine makes your body release more norepinephrine. Put them together, you get a massive surge of norepinephrine, leading to a hypertensive crisis. Blood pressure shoots sky high. It can be fatal. You have to counsel patients strictly on diet.
Okay, let's tie this all together with that case study mentioned, JR, the 90-year-old smoker with renal insufficiency. How do these factors play out for him?
Right, JR is like a walking collection of PK/PD challenges. His smoking likely induces certain liver enzymes, speeding up metabolism for some drugs, maybe making them less effective. His age, 90, and his low CRCL of 32 LONs, that massively impacts his ability to clear drugs through the kidneys. Their half-lives are going to be much longer, increasing risk of accumulation. And then his obesity, maybe a high-fat diet, that changes his body composition, affects drug distribution, potentially increasing the VTALs for fat-loving drugs, making dosing tricky. Prescribing safely for someone like JR means you have to constantly think about how all these PK factors, absorption, distribution, metabolism, elimination, are interacting in him.
So wrapping this up, the big takeaway seems to be that effective drug therapy is this constant balancing act between concentration and effect. PK sets the concentration, PD determines the response. And truly understanding concepts like VD11, half-life, and especially how to estimate and adjust for renal clearance, that's not just basic knowledge, it's fundamental for moving from standard protocols to truly advanced patient-centered practice.
Absolutely. And it leads to a really interesting question for you as practitioners moving forward. Think about it. Given all this complexity, the individual genetics, the diet, other diseases messing things up, how might drug development itself change? Could we see a future shifting away from trying to find the average standard dose and moving towards strategies that are purely personalized? Maybe even using real-time data from wearables or sensors to adjust dosing dynamically.
That's definitely something powerful to consider as you apply these PK and PD principles day to day. Thank you so much for joining us for this deep dive into the essential foundations of pharmacokinetics and pharmacodynamics. A warm thank you from the Last Minute Lecture team.